Hello friends, I'm Dr. Marta Perez and welcome back to Prepare for Birth. This is my YouTube channel, Dr. Marta Perez OBGYN, where we discuss everything about pregnancy and birth so you can have an educated and empowered experience. So this week we're going to finish our two-part series on genetic screening in pregnancy. In the last video, we talked about genetic screening in pregnancy, that is screening for genetic diseases that are passed down through families, okay? So that's called genetic carrier screening, and that is the last video. This video today is going to be on genetic screening of the new fetus that was created when a new egg and sperm met. Thank you for being here, and let's get started. Okay, so when we talk about genetic screening in pregnancy and we're talking about the screening of the genetics of the new fetus, that's typically called aneuploidy screening. So in my last episode, I went over a brief overview of genetics, and aneuploidy means that there's an incorrect number of chromosomes in the new fetus. The number of chromosomes someone should have is 46, and there should be 2 pairs of 23 chromosomes with a total of 46. But sometimes this can go awry when a new sperm and new egg are created or meet. The most common aneuploidy is called trisomy, meaning 3 copies instead of 2, 21 of the 21st chromosome. Trisomy 21 is also called Down syndrome, so you may have heard of it before. But there are other aneuploidies, but overall Down syndrome is the most common one and the one we're mostly thinking about when we're talking about aneuploidy screening. As a reminder, this is just a video that is trying to lay a groundwork for the foundation of getting you informed and empowered. This is not a comprehensive overview of genetics or all of the things in this topic, and additional questions should always be run by your OBGYN or midwife, or a high-risk OB doctor, or a genetic counselor, because those are the experts. So if you have any questions at all about this, please talk to your doctor. And of course, I'm speaking in generalizations, and there may be things that make you particularly higher or lower risk. Okay, a few definitions to get us started. I already defined aneuploidy, and I mentioned that trisomy 21 or Down syndrome is the most common aneuploidy, but there are other ones as well. The other topic I want to very closely define for you is the difference between a screening test and a diagnostic test. A screening test has a goal of detecting a disease without having to undergo invasive testing. There are many different types of screening tests for aneuploidy in pregnancy, but there are also diagnostic tests. A diagnostic test gives us a definitive answer about whether or not the chromosomal problem, the genetic problem, is present or absent. There are 2 types of genetic tests for genetic problems in the fetus or pregnancy. And those which one you get depends on where you are in the pregnancy. So earlier in the pregnancy, it's something called chorionic villus sampling, or CVS, which is where a sample of the cells that go into making the placenta are taken. Later in pregnancy, it's something called an amniocentesis, where a sample of the amniotic fluid is taken. Because these cells relate exactly to the new fetus and their genetics, you can test for not only aneuploidies, but also for other genetic issues. So diagnostic tests are definitive. Screening tests give us an idea of what the risk stratification are, but they're never perfect. So every screening test is going to have a sensitivity and specificity. So basically, a screening test should be sensitive, meaning it should be good at identifying true positives. So sometimes you'll see 98% effective screening test. Generally, what that means is that 98% of the time, the test will be positive if the disease is there. So with sensitivity will also be false positives, meaning sometimes it will falsely identify someone as positive that really doesn't have the disorder or the problem. And there will also be false negatives, meaning the screening test will say everything looks good, but the disorder is actually there. So it's important to know that screening tests are not perfect. Some of them are, for aneuploidy, actually very sensitive, but there will always be the possibility of false negatives and false positives. An additional thing to consider is something called the positive predictive value or negative predictive value, meaning how well a test performs not only depends on what it can pick up under pure conditions, but what it can pick up based on the prevalence of something in the population. If the prevalence or how common the disorder is lower, there is a higher chance of having a false positive. That's an important thing to remember. Again, you may not remember these statistics, but I think the take-home point is that all different tests have different performance levels, which not only depends on the test itself, but also how common the thing that we're testing for is in the population. When a screening test is positive, the next step should always be a diagnostic test. So the point of the screening test is that we don't have to do diagnostic testing in everybody. We have an option that tells us more reliably whether or not we should do a diagnostic test. There are some individuals who want to skip a screening test and do a diagnostic test right away. That's totally okay and something everyone should be offered. There are also individuals who don't want a screening test or a diagnostic test at all, and that is also okay as well. The individual who is pregnant should be offered a screening test for aneuploidy. And so because it's a guideline that everyone should be offered it should be covered by insurance. Now I'm going to talk more about financials at the end of the episode where I do more question and answer, but not every screening test may be covered per your age or risk factor, so it's important to check with your insurance company about that. Why do we screen for aneuploidy in pregnancy? Well, we screen for it because a lot of individuals would find this really helpful information to have in their pregnancy. And traditionally, we saw that chromosomal anomalies, the risks of them go up with advancing maternal age or the advancing age of the person supplying the egg. And this is because as our bodies mature, the process of making an egg can get basically not as reliable and have extra chromosomes. So I discussed before there's multiple chromosomal anomalies, but I'm going to talk about trisomy 21 to illustrate the effect of age. So the risk of having a fetus affected by trisomy 21 at age 20 is 1 in 1,250. The risk at age 40 is 1 in 86. So you can see that the risk goes up quite a bit with advancing maternal age. And this is actually, that risk of aneuploidy is where we get the term advanced maternal age, which I have a whole video on that that's cheekily called geriatric pregnancy. You can watch that for more information. And so since we've historically known this for a long time, scientists and doctors have been developing screening tests to test for aneuploidy because this is information that pregnant people and families want to know. So there's a variety of different tests and each of them has come out at different times. I'm going to talk about the main types of testing. Remember, none of these are diagnostic tests, they're all screening tests. It's called cell-free DNA. Cell-free DNA is a blood test only. It is very popular because not only is it a genetic aneuploidy screening test, but it also can give you, if you desire, the results about being XX or XY as early as the first trimester. So a lot of people are very interested in finding out fetal sex very early, and this test allows that to happen. But the point of the test is an aneuploidy screening test. There are a few pros and cons to this screening test. The most popular pro is that it also gives information about fetal sex, like we just mentioned. It also has a very high detection rate of about 99% for trisomy 21 and pretty good detection rates for other common trisomies like trisomy 13 and trisomy 18. An additional pro is that it doesn't require an advanced level ultrasound. It's simply a blood draw. It can be done as early as 9 to 10 weeks, most commonly at 10 weeks. And it has a very low false positive rate, which is really great because it has a lower chance of causing undue distress from a false positive. There are, however, cons to this test. It was first developed in the high-risk population, age 35 and above, but now is mostly available for people younger. However, insurance might not cover it, and so it might be pricey. It also can't be used in certain populations, such as transplant recipients, people who have had a vanishing twin, and it may reveal underlying maternal aneuploidies, actually. Before cell-fetal DNA was available, and still for women under 35, another screening test is a combination of both a blood test, which looks for certain hormone levels in the blood, in combination with an ultrasound in the end of the first trimester that looks at the thickness in the fluid level behind the fetal neck. When you combine these values into an algorithm, it gives out a result about being high risk for aneuploidy or low risk for aneuploidy. This is commonly called first trimester screening, and it has advantages and disadvantages as well. It's about 82 to 87% good at detecting trisomy 21. And some of the advantages are that it's typically covered by insurance without adding extra cost for the individual. Another advantage is that piece of the ultrasound where it's looking at the nuchal translucency, that can also screen for things that are not genetic disorders. Things like problems with the fetal heart or digestive tract or neurological system that may not be obvious until much later in pregnancy, but you could pick them up early because of that. This type of screening can also be combined with another hormone draw in the second trimester, and that can add to the detection rate. And that second trimester level not only goes into the formula for detecting trisomies, but also is a screening test for a neural tube defect. So there are some advantages in the ability of doing this testing to pick up some other rare stuff that may or may not be able to be picked up on an anatomy scan, but you may be able to pick it up sooner here. So that's a real advantage. The disadvantage obviously is that we don't know fetal sex. The detection rates are still lower than cell-free DNA. And if you're waiting till the second trimester to get a full idea, then that's a lot of time that you're spending on a screening test, and you still need to move on if it's positive to diagnostic testing. Another popular screening test is called a quad screen. This is another screening test that is a blood test only, looking at different hormone levels in the blood. This test is available in the second trimester. The advantages of the quad screen are that it can be done in the second trimester, and so those who haven't accessed prenatal care or who maybe weren't offered genetic screening in the first trimester, they do have an opportunity for aneuploidy screening in the second trimester. And disadvantages are that the detection rate is lower, it's about 81%, and it doesn't pick up on those other things that the other two tests do, such as fetal sex and also some other anomalies, although it can pick up on some of them from hormone levels. I really want to get to some frequently asked questions because there are a ton when it comes to this topic. A lot of times I get questions about, can I get more than one screening test? That's not typically recommended, especially if cell-free DNA is one of the screening tests that is done, because it actually has a very high detection rate. And if you're combining a test with a good detection rate and one with a not so good one, what if the not good detection rate is positive, but the high detection rate one is negative? It creates a clinical conundrum and possibly some undue stress and lead to diagnostic testing. So usually an individual is going to pick one type of genetic aneuploidy screening and go with that. I mentioned earlier in the video that cell-free DNA is done by a lot of different companies, and it was first approved and marketed to those supplying an egg or maternal or egg donors who had been over the age of 35, and that's what insurance covered. However, it's a very popular test, and because of its high detection rate, it is usually also offered for individuals under 35 years old. And sometimes some insurances will cover it, even under 35. They say, look, this is a good test and it's something we'll cover. But not all insurances will. So there's two ways to get around that. One way is that a lot of the companies, they want to take your money and do the test. So a lot of times a company will say, okay, well, don't even bill your insurance, don't use your insurance. This is the price tag for having the test without insurance, without using your insurance. That can range anywhere from what I've seen to like $150 to $300 as just like an out-of-pocket flat fee without using insurance. But there should be some type of genetic screening covered by your insurance. So if cell-free DNA isn't, and you don't want to pay the out-of-cost outside of insurance fee, you should be able to access the other types of screening tests. Another really common question I get from people is, do I have to get genetic screening? And the answer obviously is no. This isn't a necessary test for pregnancy. Many people find this information helpful for many different reasons, and many people would make decisions about the pregnancy based on this information. But there are some individuals who don't feel like it would affect their decision and they don't want to know. But for some of those people, I do ask that they think through a few different scenarios. First of all, one of the common reasons I hear for not wanting genetic screening is that, well, I'll just get my anatomy scan, and at that point, you'll be able to see if something is wrong. That is not quite true. In one major study, only 27% of individuals whose fetuses had trisomy 21 were identified with structural anomalies at the time of the anatomy scan. So sometimes trisomy 21 is associated with fetal anomalies that are picked up on ultrasound, but not always. So ultrasound in itself and the anatomy scan is not sufficient to pick up chromosomal anomalies. Other types of aneuploidies do have a higher risk of having anomalies on the anatomy scan, but that 27% rate for trisomy 21 means that we really need better screening tests, which we do have. So I want to make sure the patient knows that other tests that you're already going to receive in pregnancy don't take the place of a screening test. The other thing to consider is that there is a range of medical needs for a fetus or child after birth with a chromosomal anomaly. Often that knowledge that your fetus is going to be a medically complex individual who has a lot of additional needs is really important information for a family. For example, maybe they'll need a lot more support, especially if they have other children, and they're maybe need to move locations to be closer to a support system or family. One individual or parent may not be able to work because of the medical needs of the child. Many times they're in the hospital and need a lot of medical care and extra therapies, and so it can really affect someone's career and financial planning as well. So that's why I feel like the information is important to have, but certainly no one needs to have this information ahead of time if they don't want it. Another common question I get is in twins. So twins and genetic aneuploidy screening can be a little bit of a complicated topic with nuance. I will definitely advise you to talk to either a genetic counselor or a high-risk OB doctor about this, but just briefly, what's interesting to consider is that if the twins came from the same egg and sperm, then they have the same risk as the age-related risk of aneuploidy. But if they're a different egg and a different sperm, then you kind of are rolling the dice twice, and there should be about a 2 times risk compared to the age-related risk of aneuploidy because there's 2 different chances for aneuploidy based on age. The point is that some of the screening tests may not work. So there is a company that's Cell-Free DNA does market to twins and says they have a good detection rate in twins. The research is not robust around this, but you might be able to opt for that test. In addition, the research is not very robust about some of the analyte or blood test screening, but the nuchal translucency alone is usually something that's reliable to do. In addition, someone can always do the diagnostic testing if they have twins and want to know for sure about aneuploidy in the twin pregnancies. So definitely it's kind of a bigger topic that I just briefly overviewed some considerations, but you'll need to talk to your doctor and probably a high-risk doctor about this topic. Another really popular question is that for individuals and parents who have undergone IVF and undergone PGT or pre-implantation genetic testing, is genetic screening recommended for those individuals? And the answer is actually yes, it is. Another thing that's been a hot topic in the news lately, there was a recent New York Times article that discussed the fact that many of the companies that can perform cell-free DNA use their technology to try to also screen for genetic problems that are not large chromosomal anomalies, meaning smaller genetic problems that are a series of genes or even single gene disorders. There was a lot of flack in this article because it basically said that there were so many false positives that we shouldn't use this test at all to screen for those individuals. And I'm going to say something really important to remember is what I talked about at the beginning of the episode. As we talk about screening for diseases or problems that are more and more rare, it decreases the ability of the test to adequately predict the results. And so typically screening tests want to err on the side of catching more individuals at high risk so they can go into diagnostic testing. And because of that, that can increase the rate of false positives. So I am more a fan of nuance and not attention-grabbing headlines. And I feel like we just really need to counsel individuals about what the test is, what the detection rate is, and the rate of false positives if we're talking about screening for things other than aneuploidy with the cell-free DNA test. I do think, genetic technology is absolutely exploding. And I do feel like with that, there are opportunities, but we need to be cautious about really understanding and counseling patients about statistics and genetics and some of these complicated topics. And I honestly feel like that is in the realm of the high-risk OB doctor and genetic counselors. It's even hard as a general OBGYN, this is why I'm going to fellowship, to really get a great handle on this. So if these tests are offered through cell-free fetal DNA by some of these companies, they need to be discussed with nuance in the patient, and the patient really needs to understand why they're getting those add-on tests and choose whether or not they want them, given already the outset knowing that the risk of false positives is going to be higher because these have a lower prevalence in the population. Another popular question I get is that sometimes kind of the overwhelming nature of the first trimester has people feeling a little bit like, well, I don't maybe need that test, or maybe they're worried about financials. And then as pregnancy goes on, they might want to get this screening test. So I mentioned how the screening test that is first trimester screening is in the first trimester, and then the quad screen is second trimester. But another advantage of cell-free DNA is that it can be done throughout pregnancy after that 9 to 10 weeks. And so that's a benefit, is that it can be done all throughout. As I talked about in the beginning, no test is perfect. There will be both false negatives and false positives. And there are some other limitations to cell-free DNA particularly, and it has to do with maternal weight. So if the person carrying the pregnancy is over 250 pounds, there is a lower what's called fetal fraction. And the fetal fraction is the amount of that cell-free DNA that's in the blood draw. And if the fetal fraction is lower, then the ability of the test to perform is lower as well. And so sometimes there's what's called a no-call result. Within no-call results, sometimes it can be recommended to repeat the test at a later gestational age, and that may result in a actual call with a high enough fetal fraction, but it can also mean that no-call results have a higher rate of actually being positive for aneuploidy as well. And so some of these topics are hard to counsel around and may not be results that someone is expecting, especially when they're expecting like a yes or no for the screening test and they get a no call. As I mentioned before, there are some individuals that can't have cell-free DNA testing, like if you've had a solid organ transplant, a vanishing twin, because the twin that vanished, some of that DNA may be in the maternal serum, and we know that miscarriages, which is what a vanishing twin is, have a much higher rate of aneuploidy. The most common cause of a miscarriage and of, a vanishing twin, which is just a miscarriage in one of the two fetuses, is aneuploidy. And so that's an important thing to remember as well. All right, so that's my episode on aneuploidy screening. I would love to answer more of your questions about this. I can probably do follow-up episodes about this as well, particularly. So please ask your questions in the comments. I'm so glad you're here. This episode was a little more complicated and technical, so I'm gonna get back to doing things that are a little bit more fun in the next few episodes, but I do feel like it's just such important information that's really confusing. And as an OB doctor myself who is in these first trimester visits, you're discussing so many things that sometimes it's hard to have, I don't know how long this episode is gonna be, 15 or 20 minutes just to discuss this scenario. So my goal is to give you a step ahead before you go into the OB's office for that in that first trimester visit, where they're going to offer you screening tests and have some background knowledge and then talk about your individual situation. So as always, thanks for tuning in. Do not forget to hit subscribe because you definitely want to be here for both my technical episodes and my more fun ones. Take care, and I'll see you next Friday.